if I could get the graduate student / table facilitators to come up here, and we'll get you to do the reporting back. All right, everybody, if you could come back, if you've got your drinks. Now, I wanted to remind my people, out of this, we know where your email addresses are, and out of this, we have a few products that are going to come. Now, this event has been recorded for the live stream that's been happening, but it's also going to be posted immediately on the university's YouTube channel, so we'll be sending everybody a link to that in case there are any of the presentations that you are wanting to rewatch, or if you're wanting to send anybody else a link to one of them. In addition, the presentations from, I think I haven't asked all of the people, but I think most of our presenters have said that they are fine with sharing their presentations, so we'll make sure that that goes out in a package. And the presentations that you're about to hear, I'm dragging out the time for an extra minute here to give our table facilitators a chance to gather their notes. They asked me for 2 minutes. And so we will be doing a summary document of the table discussions that have just occurred. So you'll be able to review those. I think there's a lot of links, some good conclusions, flagging lots of issues from what I was hearing around the table as I was doing my walk around. Okay, so what we're wanting to hear is a summary of what was happening at each of the tables. I know many of you have a broader interest than just the 1 or 2 tables you were able to go to, so this might mean that you'll flag something in one of the other presentations that you would like to hear more about, so we'll be able to connect you to that afterwards as well. Okay, who is ready to be able to come forward? Nobody's quite ready. Okay, Joelle.
Okay, you might have to bear with me as I flip through my notes. We're doing our best up here, and I'll go first to give everyone more time. So I was at the table with Ginny Lane and Ramona speaking on seniors. And really the primary concerns that were raised as far as the perspective of seniors would be the good quality of life, aging in place, and that currently there's not appropriate services and supports to be able to age in place. So those were kind of the key overarching concepts that were discussed. If we're thinking about patient-oriented research, there was the question of how do we engage older adults? That was an important consideration, as well as that older adults do not view themselves as ill or elderly necessarily, and that they're not a homogeneous group. So there's multiple generations of people who are considered older adults, and they'll have very various needs that are not necessarily being met. So there was a lot of discussion about rural versus urban, the differences as well as similarities. And in Saskatchewan, there was a lot of discussion about northern Saskatchewan and the barriers that are being seen in that population and how they access services, especially when you think about the geographical location. So some of the questions that were being asked is, and these are questions that kind of seem to resonate with multiple people in the group, so I'll focus on them, is what does aging in place mean? That's something that was being said a lot, is aging in place. People want to age in place, but what does that mean for people? And what do they need to be able to do that? And a lot of this came to kind of intersectoral non-medical support services, really looking at community-based supports, as well as acute medical services. So that was a big question. There was a discussion about rethinking the home care program, again, looking at not only acute medical needs, but those community supports. And there was discussion of a few pilot projects that are ongoing. I think there's one mentioned that was going on here in the city at Preston Park. And rather than calling 911 for a fall, bringing in EMS, police, and fire services, and looking at how that does for the care of seniors. Okay. Where we really kind of ended up from all of this is that there was a lot of pilot projects going on. There's a lot of research. There is some links going on already with the Health Quality Council. There's research going on at the university in rural and remote areas, but there's a lack of translation between organizations and between groups to know what's going on. So there's questions being asked, and it sounds like there's already data out there that might help answer those questions, that would help then foster new questions. So collaboration could then occur moving forward to answer joint questions. So there wasn't necessarily a project that came out of the seniors group, but it was really looking at, this is a concern, oh, well, we've kind of looked at this aspect of it, maybe not the whole problem, but there's an aspect of it that we've looked at. For example, there's been research done into how seniors are accessing information about health, and that there's a lack of available information on healthcare services and supports. So I'm going to leave it there, I think. And it sounds as though anyone who's kind of interested in the seniors research projects are going to be moving forward by networking and sharing information, and then moving forward from there.
Hello. So I was at the group that looked at ED wait times, and I'm going to preface my summary with the statement that wait for the full notes when I've properly processed the amazing and intense and highly detail-oriented discussion that we had. But if I can do my best to summarize it in 5 minutes or less. So Graham took us through the ED waits and patient flow implementation strategy, and I'm sure if you ask him very nicely, he will give you a copy to take home. And so we discussed many aspects of this, but of particular note was the scale to which this project is underway. That he talked about the environmental scan and lit review that they had done, and the UK and Australia are sort of leading the way in some of these efforts, but the scale to which the Saskatoon Health Region is undertaking this is pretty unique. And one of the biggest things that's coming out of this is the development of a predictive model to support evidence-based decision-making, both within the region, both at the ministry, and I guess just in general in terms of resource allocation. We discussed a number of challenges, some of which Joelle already covered in terms of, say, for example, rural and urban, but another one that we discussed were the challenges of working in interdisciplinary teams, and overall, it was understood and recognized the value and importance of that kind of work, but the on-the-ground, real-life challenges of managing different stakeholders, people coming at it with different interests, different timelines, different resources. And we talked a little bit about the idea of a one-stop shop, but then how to make that more meaningful than just a place that has a bunch of specialists. How do you actually work with that so that they all connect in a way that's meaningful and ultimately supports patient-oriented outcomes? In terms of projects that we discussed, there is some interesting stuff happening at SciAst. So for example, there's one, enhancing safety engagement with the mining industry through behavioral change. A super neat one that we discussed is a patient simulation project. Where is she? And it's the way that she explained it, actually, the way she explained it was really neat, that it's kind of a computerized mannequin. It's a computer that looks like a human, and students have an opportunity to engage with it, practice in a safe space in terms of bedside manner, in terms of working with potentially difficult situations, so that they have an opportunity to work through some of the stuff before they're actually with a patient. And we spent a good deal of time talking about complex care needs, or complex needs patients, and the different ways to work with that. That's where it sort of tied into the interdisciplinary issues I mentioned earlier. And a specific example that we discussed was Krista Berg's group, the pediatric complex care, and and she shared with us some of the successes, challenges that they've had in working with that model. And I encourage you to speak with her if you have more questions about it, and wait for the notes.
Yes, hello. It was my pleasure to facilitate the group with Margaret Baker. So 4 main issues came up in our discussion. The first issue centered around reserve services. Another issue was a suggestion that perhaps innovation within the languaging of innovation sites might be something that could be traded in for a more appropriate use of a focus on the key areas of access, chronic disease frameworks. Another issue that came up, issues of evaluating the components, and there was a discussion about what are the measures of this spread in this particular strategy or these particular strategies or initiatives. One of the main issues that we spent quite a bit of time discussing it was distribution of health care resources, and within this issue there are probably another 8 issues that were addressed about distribution. Certainly human health resources planning, a major component of this, proportion of resources, our providers working to their full scope of practice, as Margaret was sharing with us earlier this morning. So there were several ideas that came out about distribution issues with research and with patient engagement and community engagement. There's certainly lots of interest in the EMRs. There were challenges that were put forth in relation to that teams don't necessarily talk together. They would like to talk together and they'd like to work together, but that doesn't necessarily always happen. Lots of concern about ratios of providers and populations, and certainly that feeds back into some of the main issues with respect to rurality and differences between urban and rural needs, and urban, rural, and remote needs as well. Lots of discussion of continuity of care and how that provides solutions, and also certainly provides challenges as well. We talked about some of the issues of measurement and the challenges in measurement, and some counterintuitive perhaps issues where it may be easier to measure things like catchment in rural areas rather than urban areas. And many of the people at our table had research expertise and knowledge about proportion issues, more than 3 kilometers of distance between the service provider and the population creates difficulties in going elsewhere. So there were lots of ideas presented for potential solutions, looking at the physician survey, needing more accountability for fee-for-service, looking at different compensation models and the challenges and inherent potential solutions within different compensation models. So with respect to that, there was certainly things that seem to be working well. The CEC's working well, and lots of report back from different areas where that model is working well. Service disruptions are essentially non-existent when their full models are working, and there is questions about is there a need for more information and research on is a full model always necessary, or would components of those CECs serve? So lots of issues within those overriding parameters. So a project idea, there were suggestions for collaborations. Saskatoon Community Clinic is very much interested in a service mapping project, looking at the potential for shifting resources. What are the peak hours? What are the peak service hours? How would that work within different compensation models? School of Physical Therapy has projects on the go that could certainly be beneficial in collaboration, looking at e-health technologies. How are those used? And the Sask Health region is also interested in contributing or collaborating potentially in a project that would look at how do we manage work-life balance with providers and accountability within different compensation models, and how does that trade off in terms of meeting the community's needs.
Hi everyone, I help facilitate the group with Dr. Muhajirin and Krasnowski on early years health, and we talked about three main topics. The first was hotspotting for early years, and a large part of the discussion involved the availability of data, and one thing that we talked about was the in-hospital health questionnaire, EDI, and other indicators and outcomes available from Public Health Works, as well as accessibility to this data, as it's often seen as a barrier of looking into information surrounding this. We also talked about confidentiality and how you would maintain that in a respectful manner, whilst in the meantime obtaining very rich data around sometimes sensitive issues, such as like the death of a child. And potential products that were discussed involved breastfeeding in early years and outcomes from it, and this is based off the Manitoba model, which matches the priorities of health regions such as that of Saskatoon's, as well as using data from dental screening in children that occurs every 5 years. A second topic that we focused on was the maternal mental health and Healthline. So we looked at, say, an individual when they're identified with mental health issues, when they're, say, postnatal, and if they use the Healthline and other effective services that could surround it. So in the current situation, if they're identified by the service, is it effective in how they respond to it, or can there be alternative methods, such as using text messaging? There was other discussions surrounding maternal mental health, and is there ways of identifying them in the system through other manners or through other individuals, such as earlier providers? And there was, just give me one moment, please. Within the first two topics, so maternal mental health and early years hotspotting, one thing that we talked about was the valuability of looking at people with similar trajectories, so people that follow a similar path but have very divergent outcomes, such as a very poor health outcome versus those who didn't, as it's just as valuable to understand people who don't reach that critical point. And the final thing we talked about was systems learning from critical events. So in the current state in hospitals, there is a critical event reporting system, but once someone leaves a hospital, this is no longer reported because it happens outside of hospital barriers. So it'd be important to use things like anecdotal information and almost evaluate it as a critical incident, and how can we use this information to better reach or to better address incidents that happen both inside and outside of the hospital.
Yeah, I was at a table with the mental health group, and most of the representatives were coming from the Ministry of Health, Saskatchewan Ministry of Health. So the discussions were around the initiatives that the government is putting in place to ensure that people with mental health issues in the province are taken care of. Unfortunately, I couldn't borrow anybody from any other health region to be on my table. I wanted to get perspectives of people from other parts of the province, apart from the federal, the Saskatchewan Provincial Ministry of Health. So the government is working with several organizations in the province to ensure that people with mental health issues are taken care of, their needs are taken care of. So the government has the mental health action plan. But when it comes to the issue of policies, I asked a direct question if the government has a well-established policies regarding mental health delivery in the province, and I was told there are no such policies. However, the government is working through the health regions to deliver quality mental health care. From my understanding, the government believes that people at the grassroots know better the needs of the communities they are serving. Now, there are some identified priority areas which the government is looking into to ensure that people with mental health are taken care of. One of such areas is wait times, how to reduce that. Then they have the suicide protocols, the self-care, the patients with complex needs, and also emergency care delivery of service to people with mental health. The question of oversight was discussed, and the government representatives indicated that the Ministry of Health is monitoring the delivery of mental health services across the province in collaboration with the health authorities. So the health authorities are given the mandate to deliver quality service, and then they report back to the Ministry of Health regarding what they've done. The issue of research was discussed, and the government has some specific areas that need research investment. One of such areas would be early detection of mental health in the primary healthcare system. In this case, we are going to involve frontline health providers like physicians. So now when a person goes to the hospital for, let's say, stomach complications or any other complications, the physician will have the opportunity to do kind of mini assessment and then report back to the ministry. So there will be some protocols in place to ensure that the person's privacy or rights are not violated. And then research in areas of cultural appropriateness of mental health service delivery will be also welcomed. And how can we effectively and efficiently apply best practices from other parts of the country and beyond? Research involving active participation of the First Nations is also an area that needs to be explored, because it was discussed at the table that many times researchers talk about participatory research involving people who are of the marginalized populations. At the same time, their voices are not present when it comes to developing the research protocol and then the goals and objectives of the project. So First Nations are people in this province who might have been affected in this regard. So the provincial Minister of Health is asking for research in this area. Also, research to improve workforce safety for frontline workers is also important. Example of child services workers. These are people who are going to homes. Some people are going to business places to have contact with their clients, and sometimes they are put in danger. So what are some of the approaches we can implement to ensure that these people are also protected in the process of serving? And research that will also help the ministry to be innovative in mental health delivery will also be welcomed. These are some of the areas we discuss at the table.
So we had a discussion about hot spotting and complex needs, led by Dr. Neudorf and Dr. Quill. So as you know from the previous presentation that the hot spotters tend to be expensive and with poor outcomes. So the vision of hot spotting project is firstly identifying the high users. And also what are the services that are missing that are making the hot spotter to use the emergency service more than other. So finding the gaps from not only the patient's perspective, as well as the clinical, as well as the research perspective as well, was one of the vision of hot spotting project. Now the second phase is preventing the high users, the next high users. So once we focus on the high-risk group, we mostly tend to overlook the next high users who are going to be the next hotspotters. So how we can prevent that, and how can we predict their need or unmet need. And there was also discussion around the intersectoral approach to provide upstream intervention, and also at the different level of the care, and also identifying the different data source is one of the important discussion topic during the session. Now, linking the data, we often can have the information about that how they're accessing the services, but what are the services they cannot access? So for that perspective, we need qualitative data for those missing data. Now, there was one issue around that how can we contact those vulnerable population, because there is no direct incentive for the patient, and also balancing the focus of the risk, as well as the patient's perspective, was one of the issues that came up during the discussion. Now, there was also discussion around linking different type of data. For example, for the mental health and addiction group, maybe the school absenteeism and the dental carriage can be one of the important aspect, because as Dr. Quill mentioned, that health is mostly about the health status or the social aspect of the patient. Now, for the subset of the group, there are discussion around the other way of addressing the gaps, for example, finding the predictors to mitigate the problem. And also in the discussion, there was one example of the BC. They have a complex needs clinic. And also, there were a lot of different barriers that we talked about. One of the barrier is balancing the ethics and proceeding with the project, because sometimes balancing the ethics approval, by the time we have access to the data, probably is the time to actually eliminate the data. So how can we actually balance that issue? So last but not the least, there should be patient voice in all the phases, because it's a patient-oriented research, and having a patient voice and advocacy is in need to proceed with the project. Thank you.
Okay, thank you to our facilitators. They've been very busy in the last while. All right, as I was listening to those summaries, I was counting off, and I heard more than a dozen specific project ideas that have come out of it. So what's next? Some of you already have projects and ideas that are on the go that you might want to look at seeing if we can assemble a phase 3 application for a project within SPOR. And so we can talk to you about that. Some of these other ideas, we will be assembling this package. If you've heard an idea from here that you're wanting to pursue more, either as a principal investigator, see if there's a team that gels around one of these areas, either for an application within this next funding opportunity, or for something that might be a bit more elementary, in the elementary stages than that, please also talk to us, and we'll see about making connections between you members of the network and seeing if there might be something that comes of that. In addition, as was mentioned earlier, we're starting to receive the lists of projects from other provinces, and I know some of the areas that we're talking about here are also reflected in projects we'll see coming from the other provinces. So as those come, we will be distributing those. Please take a look and see if there's something that resonates with you, projects that you might want to be participating with. You know, we had one where we put Newfoundland in connection with some people that we have in pharmacy for one project. I mean, those kinds of connections, I'm sure that you have your own connections in other provinces, but we don't all know everybody who's working in other areas, and that's one of the main roles that we're able to offer for you as well. So we're going to be, I know it's been a very long day for everybody, so there's been a lot of content, but we'll be putting a lot of that together. We'll be sending that out to you, and please review it and see what flags, I hope that there are connections that you've made today that you find valuable, and will keep up and find the phone lines more open, the email lines more open if you have any questions or wanting to pursue. I also want to note that we have coffee and juices and things still around here until 4 o'clock, so if you're wanting to have any further conversations, we still have the room, and please feel free to pursue that. So, Nazim, did you want to add as well? Absolutely. Absolutely.
Folks, it has been a long day, about 5 hours of a lot of information. I think it was mentioned, information-rich morning, continued by information-rich lunch as you were feeding your bodies, and also feeding your soul and maybe brain, and then actually sort of having conversations with each other. We were hoping by the end of the day we would have had a chance to converse about our interest, about connecting with people who have similar interest, who might be willing to continue that conversation after today, particularly in light of calls for proposals in phase 3. I feel that we have got there, that we have some work to do, and connections to build on as we move forward. And Janice, I think one of the things that we do need to do is to really systematize all the information we have and kind of channel it back to people who are on our list, in our membership list. Some of you are here, others who are not here. So we'll continue to do that, make some sense of the summaries that you just heard, make it a little bit more elegant, make it a little bit more kind of, line up to certain themes and feed it back to you. Folks, the last thing I want to do is to say some thank yous. You wouldn't believe how quickly this session was put together by Janice and the team, but particularly Janice and Joanne. We were having conversations as late as probably in July about the wisdom of having this session on the 14th of September. I think we pulled it off, and we do need to, like I said at the beginning, this is only the first conversation. We need to continue. So this all wouldn't have happened if without someone like Janice taking charge of that. So let's actually give a thank you for Janice Braden and for Joanne Blythe. I also want to thank our colleagues who came up here from Regina. It's a whole day's worth of traveling and giving time. There are multiple people who are here, and as an epidemiologist, I multiply hours given by number of people. So person hours add up to big numbers very quickly. So thank you very much for Janice Colquhoun and your team, Margaret Baker and your team, And again, I think without your participation and engagement being the operative word here of the day, I don't think Saskatchewan could move forward as a part of a pan-Canadian patient-relevant, patient-centered research initiative. So thank you very much. Travel safe back, and we'll see you again soon. And for others who live closer to here, again, we'll see you again very soon.